Good morning, everybody. My name is Jeff Mandak, one of the heart docs up at Fulton County Medical Center. And today we're going to talk a little bit about an introduction to what coronary artery disease is and how it can affect you and your families and that sort of thing. So I have kind of a bunch of slides to get started with. If you guys have questions in the middle, please interrupt, because if you wait to the end, I know I forget all the questions I have when I get to the end. So feel free to ask a question in the middle about anything. So, sports, anything good. You're okay with it.
What'd you bring us for lunch?
I don't know. Looks like a salad right there. So basically today we're going to talk about the scope of the problem of coronary artery disease, describe what it is, what is the process by which it forms, what are the factors that contribute to the development of coronary artery disease, what we can do to prevent it. And then lastly, we'll talk a little about something called sudden death. And I know we just had a soccer coach that was in here. It's not sudden death on the field with overtime. This is sudden cardiac death, which is not so good. So if we look at the, as cardiologists, we're very competitive people. Got to go through med school, and a lot of us played sports and that sort of thing. So a lot of us have I forgot my foam finger today. I have my foam finger. I said, we're number one. We're the number one killer of people in America. And I'm thinking, oh, that's not a good thing to be number one about. And that's the problem, that despite all the advances you hear about, you guys watch 60 Minutes or all these other TV shows and ER, you hear about all these wonderful advances in medicine. But unfortunately, despite everything that they've done, coming up with new ways to put in stents and putting valves in with catheters and all that, we're still by far the number one killer of Americans. And if you add heart disease and stroke together, they're higher than everything else put together. So it's over 50% of people die from heart attack or stroke. And that's a problem. Now, one thing, if you look, I know this is the business department here of JLG, so you guys are good at bar graphs. We always thought, if you think about 20 years ago, when I was first in medical school, we thought, well, coronary disease, that's an issue that guys get. Guys get coronary disease. But when you look at the bar graph here, women are in purplish and guys are in bluish. More women die of heart disease than men each year, just 10 years later on average. So if you compare a 50-year-old man to a 50-year-old woman, yeah, that guy is maybe at higher risk. But when you look at the whole population, since women live longer, more women die of heart disease than men. So it's not just a problem of guys. So the scope of heart disease is that it's still the number one killer in the U.S. There's about 1.5 million heart attacks per year in the U.S. And about a third of these people die before they ever reach the hospital. So that's why prevention is so important. Once you get to the hospital, we're down to maybe, 5–7% of people will die with a heart attack after they make it to the hospital, at worst. But a third of people die before they ever get to the hospital. They die at home, they die at work, and that's what we're trying to prevent. So let's go back to your high school biology classes where you learned a little bit about the anatomy and physiology. So we have blue blood and red blood. And it kind of looks that way. So the heart is the pump that keeps everything going. Since I'm a cardiologist, it's obviously the most important organ in the body is the heart. I'm not biased by it. So we have the heart that pumps blood out, the red blood out to the rest of the body. It goes to your brain, it goes to your arms, it goes to your legs. Those muscles, the brain, the different organs take the oxygen out of the blood. And then as it takes the oxygen out, the blood turns kind of blue, becomes the veins, ends up in something called the superior vena cava, goes back to the right side of the heart. The right side of the heart then pumps the blood out to the lungs, where, this is the lungs down here, the blue blood then turns red, and it goes back to the rest of the body. So that's kind of the circulation. The right side of the heart pumps blood to the lungs, gets oxygen, comes back to the left side of the heart, and then gets pumped down to the rest of the body. So the heart muscle is just like your arm and your leg. Even though the heart is full of blood, it's a chamber full of blood, the oxygen doesn't go right from the chamber across into the heart muscle. Just like every other organ, the blood gets pumped out through the aorta, which is the big blood pipe coming out of the heart, and then goes into these arteries called the coronary arteries that serve blood to the heart muscle. So the heart muscle is a muscle just like your arm or your legs. Just like you have a pulse in your arm and you have a pulse in your leg and that sort of thing. We have an artery that goes to our heart. We're not very creative in cardiology. The one that comes down to the right side of the heart we call the right coronary artery. The one that comes down the left side of the heart we call the left main coronary artery. And then that one splits into the one coming down the front called the left anterior descending, or LAD, and the one wrapping around the back, the circumflex. Those are basically the three arteries of the heart. So when somebody says they had a triple bypass, that means they had blockages in all three of these main arteries. If somebody had a quintuple bypass, that means they also had some of these branch arteries bypassed. So you basically have three main arteries, and we'll talk a little about this as we go along. So what happens is these arteries deliver oxygen to the heart muscle. That's what keeps the heart muscle going. So what's coronary artery disease? Well, coronary artery disease is when those arteries get plaque, atherosclerosis, hardening of the arteries in those arteries that are serving blood to the heart muscle. Now, because those arteries are constantly moving, 80, 60, 100 times a minute, there's a lot of activity going on in those heart arteries. So there's a lot of blood flow, and they're prone to get damage. When you get a blockage in the artery, then, that leads to angina, which is chest pain, heart attacks when there's a acute blockage of the heart artery. And then if you have a heart attack and the heart muscle gets weaker, that's when people develop heart failure. So terms like heart attack, heart failure, they're different meanings, but they all kind of come from the same area. So what's the biology? How does this happen? Well, the first thing that happens is that there's an injury to the lining of the heart artery wall. So who's ever gotten yelled at or yelled at their spouse for using a metal fork on a Teflon frying pan? Anybody ever yelled at their spouse or gotten yelled at for that? And why is that? Because if you're making scrambled eggs and you use a metal fork, what happens?
You scratch it up.
You scratch it up. And then what happens the next time you go to make scrambled eggs?
It sticks.
Exactly. That's exactly what happens in your heart arteries. So when you're born, most of the time, now we'll talk to you about a case where it's not always the case, but generally when you're born, your heart arteries are just like a brand new Teflon pan out of the box. Those arteries are covered with the Teflon on the inside that prevents anything bad from sticking. But what happens is over time, different things can injure, can scratch that lining, and then stuff starts to stick to the lining, and then it starts to grow, as cholesterol causes those plaques to grow. So the things that cause the injury are things like high blood pressure, things like smoking, things like diabetes, things like high cholesterol. Those things cause an injury, cause a scratch, and then the scrambled eggs start to stick as you go along. Nobody's going to want to eat scrambled eggs on Saturday night. You still have the bacon. Anyway, so what happens is once there's a scratch, then there's different types of blood cells. There's platelets, which are the cells that cause clotting. There's white blood cells that fight infection. They come to the site of the injury, and then they start gathering up cholesterol and all those kinds of things, and the plaque starts to grow. And then what happens is that plaque, you don't have a heart attack because the plaque grows 10%, 20, 30, 40, 50. It doesn't grow like an onion skin. What happens is you may have a 30% narrowing, and then all of a sudden that cracks open, and that cracking open causes a clot to form that blocks off the artery acutely. So you might have a 90% blockage that blocks off acutely and causes a heart attack. You might have a 40% blockage. So that's why you might hear somebody say, oh, I had a stress test, everything was fine, 2 weeks later I had a heart attack. Well, it's not that the stress test was wrong, it's just that the stress test isn't good enough to pick up a 40% blockage, but that 40% blockage is still likely to cause a heart attack, and that's the problem. So that's why prevention is the key. So this is kind of a schematic of what happens, that you have the scratch, then this plaque forms, and the plaque is a lot of cholesterol and fatty tissue and cells that's covered by like tissue paper. This is called the fibrous cap of the tissue paper. And what happens, trouble happens when that breaks. So this fatty streak, this is what happens when you're a kid. So people can start forming plaque at 3 years old. And tell you a crazy story, when I was at Children's Hospital in Philadelphia, we have these kids who genetically have too much cholesterol. You know that there's good cholesterol, there's bad cholesterol. These kids had cholesterols at birth of over 1,000. When they were done ultrasounds of these kids in utero, when they were still, before they were born, they were starting to form plaque before they were even born. Now that's an exceptional case where they have cholesterols of over 1,000. But the bottom line is it's never too early to prevent risk factors, because you can start forming plaque when you're 3, 4. And in fact, if you have pristine arteries when you're 40, you're probably never going to get heart disease. So if we look at your arteries with the scope and we see everything looks perfect at age 40, you're probably good to go. You're going to die of something else. Not heart disease. That's what I tell people. That's why I eat bacon every day, because I volunteered. When you were in med school, you volunteer for experiments to make money. So every time Christmas came, I had no money to buy Christmas presents, so I donate my body to science. And one of them was I got a CAT scan of my arteries. I said, that's great, I got a CAT scan. So it told me I had, at whatever I was, 25 or something, I had perfectly clean arteries at 25. So I walked outside, okay, I'm dying of cancer. I'm going to live my life happy. So the fibrous plaque starts as a little bit of a scratch, then it starts to grow, and then all of a sudden the complicated lesion is when it cracks open and then this clot forms. So that's what these kind of show here, that it cracks and then boom. So you have this is maybe a 50 or 60% narrowing of the lumen. This is the lumen of the artery, the opening of the artery. And you can see how it cracks, and all of a sudden this boom blocks off the whole artery. And that happens in a matter of seconds. So that's why things can happen so quickly with the heart. So the bottom line, I gave you all this bad news, like, oh my gosh, stage 3. You know, what am I? I'm over 3 now, so I'm in trouble. What can I do? Well, you don't want to wait until a heart attack happens to start changing your risk factors. You know, here's a guy who's about to be hit by an asteroid calling 911. Then I'm probably not going to be able to help you. So at an early age, you have to identify, am I at risk or not? So as in any 12 steps program, and I think life is one big 12 steps program, just like AA and NA and everybody else, you have to realize and admit that you may be at risk for heart disease, that your family may be at risk, your kids, your spouses, your mom and dad, aunts, uncles, sisters, brothers, everybody. So these are the things that cause that scratch. These are the things that cause you to start developing heart disease. Diabetes, the bad one. 70% of diabetics will get heart disease in their lifetime. 70%. Yikes. Family history. If there's a really bad family history, then you're more likely to have it. Some of the family history pertains to these other things. People in family history are more likely to get diabetes or high blood pressure. There's probably some chemicals that we haven't even identified yet. And we'll talk a little bit about some of those that are kind of newer kids on the block as far as risk factors go. High blood pressure. Anything that has a star next to it, these are the things we can do. You know, there's a serenity prayer, accept the things I cannot change, have the strength to change the things I can, there was another difference. Well, anyone that has a star is something we can do something about. So if you know your blood pressure is high, that's something you want to treat. If you smoke, don't smoke. I'm not going to ask for any hands up. I know this is a group that's too smart to smoke, that's all I'll say. High cholesterol. If you have a high LDL, so there's good cholesterol, there's bad cholesterol. LDL is the bad cholesterol. HDL is the good cholesterol. Even if you don't have a high cholesterol but you have a low HDL, that's still a risk factor for developing heart disease. Age. Not too much you can do about that yet. Male gender. As I said, women more likely than men, but men 10 years earlier. So even when you look at a study, you know, some studies say, oh, aspirin, you know, I don't know if any of the women in the group read that article in Time magazine 5 years ago saying aspirin doesn't help women. But that's not what the study showed. The study showed that aspirin benefit wasn't as great in preventing heart attack as it was in men. But that's because they compared 50-year-old women to 50-year-old men. If they compared 50-year-old men to 60-year-old women, you would have seen the exact same benefit, most likely. They didn't do it that way. But then there's other studies that say that aspirin does help. So the bottom line is that male gender just pretends that you're going to get an earlier onset of heart disease. Obesity, sedentary lifestyle, stress. Nobody has stress at this work, do they? No stress. So that's good. There's something called lipoprotein. These are some of the newer kids on the block. Lipoprotein little a. You may, if you go to a doc, some docs may check for that. That's a protein in your body that everybody has, but if you have too much of it, it can cause heart attacks. What it does is your body has its own Drano that opens up clots. If you have a clot form, it's called TPA, and this lipoprotein bonds to the TPA in your own body and prevents it from breaking up clots, so it makes you more likely to get a clot. This homocysteine is an amino acid that everybody has, but again, if you have too much of it, it can cause a scratch in the arteries early on, and it can cause all other troubles too, aortic disease and that sort of thing. So these are things, anything that has a star next to it are things that we can change. Family history, although they're trying to change, you know, well, gender I guess you can change now, according to Bruce Shepard. But other things, I don't know if it changes risk factors for coronary disease there. Yes?
I think there's a lot of news or whatever in the social media talk about the government new dietary guideline. They kind of said the cholesterol is not that bad now.
Well, what they're probably saying is that cholesterol, 80% of your cholesterol is genetically programmed to be there. 80%. So even if you ate nothing but these pamphlets, breakfast, lunch, and dinner, if you have a high cholesterol, you're probably still going to have a high cholesterol. 20% comes from diet. So diet does have some impact, but not dramatic. Talking about studies back in med school, my roommate and I decided we're going to see what happens with diet and the cholesterol. We went to this one hospital in Philadelphia where they would draw your blood of the med students for free, get anything you wanted done for free. So we got our blood tested at the beginning of the rotation, and then we got these, you could buy like these huge boxes of hot dogs in Philadelphia down at the dockyards, and we decided, okay, we're going to eat hot dogs for breakfast, lunch, and dinner for a month and see what happens. And so mine didn't change at all. No, it was hardly any change at all. His went up like 100 points. So diet does have an effect, but it's not the end all. A lot of it's still genetic. So sometimes even if you watch your diet, people have high cholesterol, they may still need a cholesterol medicine because their liver is programmed to make too much cholesterol. So I suspect that's what they're talking about. Okay? Diet has an impact, but not as great as genetics. But smoking is the biggest one. I always like this slide. It's more of a little flash there. But butts are gross. And this is included in that thing here. So, what do we do to reduce the risk of heart disease? You know, what are the modifiable risk factors we can attack? Stop smoking, exercise and lose weight. And when we talk about exercising and losing weight, the losing weight part is not what you want to focus on. You want to focus on the exercise part. There was a study done probably about 20 years ago called the Diabetes Research Group, where they took people, a couple thousand people, I forget the details, who were at risk for developing diabetes. They didn't have diabetes yet, but they had kind of the early signs of it, and it ran in their families and that sort of thing. And half the group they put on medication, diabetes medicine, and half the group they said, well, let's just do routine exercise and diet. And it wasn't anything crazy. It wasn't like they had to eat cardboard breakfast, lunch, and dinner. It was, we want you to just don't eat cake for breakfast, lunch, and dinner. You know, kind of have a routine, normal diet. And exercise was 30 minutes of walking 3 times a week. That's not bad. I don't know how many hours are there in a week. You know, an hour and a half of exercise out of how many hours in a week. It's not a whole lot to ask. And 2 years later, the group that did exercise and diet did far better than the group that was put on medication for the diabetes. So it really is important to exercise. And as a side effect, you'll lose some weight. You don't want to focus on the weight loss because it never comes off as fast as you want, so people get frustrated. And the other part is, as you exercise, you lose fat, you gain muscle. Well, it's 9-to-2 density-wise, muscle to fat. So you may lose the fat, gain muscle, and actually your weight goes up a little bit. The belt is kind of the key. If your belt, I'm on my last belt here, hold here, that's not good. But if your belt gets tighter, that's probably not muscle. That's the only thing I'll say about that. Lower cholesterol. Things that you can do to lower cholesterol, whether it's diet, exercise can lower cholesterol, and then a lot of times people need medications to lower cholesterol. So there's a whole host of medicines there that work on that. Controlling blood pressure. You know, the definition of high blood pressure changes every week, it seems. But in my way of thinking, I still like the old definition of 135/85. Everybody in this room is young, so that applies to everybody here. Now, the new guidelines that just came out from the government, we know how we trust the government. The government says now, well, if you're over age 60, 150/90 is okay. Now, for some people that may be okay. Like the 90-year-old, if we try to get their blood pressure to 130, they might get lightheaded and fall, and yet we're not doing them a service by getting their blood pressure down. But for the 50-year-old, or the 60-year-old even, who's still very active and that sort of thing, 150/90 is still kind of high. So I don't agree with the new guidelines. I think they'll probably be changed next time they're redone. But anything you can do to lower cholesterol is good. Exercise, diet, weight loss, stopping smoking, decreasing alcohol use with people who drink a lot, that type of thing. Those are things that are conservative measures to lower blood pressure. And then, of course, there's 1,000 medications that are out there. Homocysteine, this is kind of a question mark. We know that homocysteine in bulk causes heart disease. We know that folic acid, which is just a vitamin, decreases homocysteine. But when they did the studies at Harvard, trying to reduce homocysteine with folic acid, it didn't seem to prevent heart disease. I'm a Penn guy. I don't trust Harvard anyway, so I just kind of throw that study out. Anybody of mine who has high homocysteine, I still treat with folic acid because there's no downside. If you take too much folic acid, you pee it out if you have too much. Now, sometimes Europeans make fun of us that Americans have the most expensive urine in the world, but that's okay because I still think there's a benefit to that. And then there's some people that are focusing on, at an age, they look at infection and inflammation. Whether there's people who have things like lupus and rheumatoid arthritis are more likely to get heart disease. Is that because of the disease process, or is that because of the medications for the disease process? So right now there's a medication called methotrexate that years and years ago was a chemotherapy cancer medication. Now it's used predominantly for things like psoriasis and rheumatoid arthritis. But now they're using it to try to prevent heart disease by trying to prevent inflammation. And then there's some infections that may be implicated as well. So these are things that we might be able to modify either now or in the future. And every little bit helps. This says here, I'm sorry the guys down at the shop tease you, but it's still healthier than smoking. Because this guy's talking this. Because a lot of the hand-mouth thing is the issue with smoking. So, what are the goal cholesterol levels? Now, these have changed a little bit too. If you look online now and say, what's the 2016 guidelines for cholesterol, they don't talk about numbers. Once again, I think that's a bunch of BS. I think that's going to change back as well. So, the first thing is you assess your risk. And we look to see, for everybody, I like the idea of less than 200 is probably a good thing, okay, for everybody in the room. If you have known cardiovascular disease, if you've had a heart attack already, if you had a heart cath and you have 50% narrowings of your arteries, then I want your total less than 160. Or if you have diabetes. Because we said that 70% of diabetics will get heart disease, we treat diabetics as if they already have heart disease, and we want to get them lower. The LDL for everybody, the bad cholesterol, we want it less than 160. Okay? For people who have never had heart disease but have two risk factors, oh yeah, my dad had a heart attack at 50 and I have high cholesterol, I want to see that LDL less than 130, that's the bad cholesterol. And if you have coronary disease or diabetes, we want that LDL less than 100, and preferentially, most cardiologists like myself who have gray hair like it less than 70, because we know lower is better. I heard somebody over here in the corner talking about, oh, my cholesterol is only 40, is that a bad thing? We don't know. You know, cholesterol to some extent is important because it's the building blocks of some of your enzymes and some of your cells and that sort of thing. So we don't want to reduce our cholesterol level to 0, but we don't want it high either, so you kind of have to find that balance. You may read about that, oh, cholesterol medicines cause dementia. I'm not sure if that's true either. There's something called a confounding variable in science. Anybody here are statistics people? If you are, you hear about the confounding variables. An example of a confounding variable is that I can prove to you that yellow fingers causes lung cancer. And we can say, well, does that mean that if I paint my fingers yellow, I'm going to get lung cancer? Well, the confounding variable is that people who smoke have yellow fingers. And smoking causes lung cancer. But painting your fingers yellow doesn't cause lung cancer. And that's kind of what I think is going on with the statin drugs, like Zocor, Lipitor, those drugs, that if you take a statin, it's already proven, you're going to live longer. If you die at age 50, you're probably not going to get Alzheimer's disease. If you live to age 80, you're much more likely to get Alzheimer's disease. So I'm not sure if cholesterol medicines have an effect on your memory or not. They may, because cholesterol is part of the brain metabolism and such. But I think some of that is a factor of the fact that people are just living longer when they take these medications. And then HDL, the good cholesterol, we like everybody's HDL to be above 40. If it's above 60, that's great. So the thing is, it's important to improve your lifestyle, attack all of these risk factors. You don't want to just attack one and not attack the other. Anybody recognize this guy? His name is Jim Fix. Back in the 70s, he wrote a book called Running. And that's what started the running revolution. Nobody in the 40s or 50s ever ran. You never saw people jogging like you do nowadays. But this guy was a physician. Every male in his family died before age 50 of a heart attack. So he decided, hey, I'm going to go running. And it worked. He lived to age 51 and died of a heart attack at age 51 because he was still smoking. So the thing is, you can't just address the one risk factor of exercise. You got to do everything else. And this guy, we know him, he would run, but he ran to McDonald's to get a cheeseburger. So that didn't really help him out so well. It's kind of an interesting thing that you have to attack all those areas. At Fulton County, for those who live up in Pennsylvania in our area, we do have a wellness program. Kind of a little commercial I'll throw in the middle here. But you can do this anywhere. We have our nurses provide a guided exercise program for those interested in both primary and secondary prevention. Primary prevention means that we're trying to prevent you from ever getting heart disease in the first place. Secondary means you've already had trouble, we're trying to prevent it from happening again. So we have exercise programs, heart rate and blood pressure monitors are available, achievement of milestones, lots of education. So when somebody has had heart disease, a lot of people you may know go through something called cardiac rehab. And that's a wonderful program to get people's confidence back to live their life. But there's also, not only are they exercising, but they get a lot of education of what to do. So there's a lot of these programs in your community. If you have a YMCA, YWCA, they have lots of these types of programs, and it's good to get involved in. If not, it doesn't cost you anything to exercise. Just go for a walk. Don't get hit by a car. Walk somewhere safe. But otherwise it defeats the purpose. But anyway, there's lots of progress in heart disease. We know lots of new medicines, lots of new techniques that we do, all kinds of fancy stuff. But the bottom line is, just like I said in the beginning, a third of people still die before they get to the hospital. And the reason they die is not because the pump is so blown out. The heart doesn't explode. Because you hear them say, oh yeah, my grandfather died, his heart exploded. Well, it didn't explode. What happened is that they had a sudden cardiac arrhythmia, which led to sudden cardiac death. So normally when the heart beats, it's a nice regular beating, 60, 80, 100 times a minute. But what happens is there's an irregularity when the heart has a lack of blood flow, and this can happen for other reasons too, where they just get this fibrillating of the heart. It just kind of flutters, and it just shuffles the blood around, but nothing gets pumped forward. And that's what sudden cardiac death is, or sudden cardiac arrest. So a heart attack can be a source of a cardiac arrest, but they're not exactly the same word. They do mean different things. So what's the treatment for ventricular fibrillation? The treatment is to shock it out. You can't bring somebody back by CPR if they have ventricular fibrillation. Now, if somebody's struck by lightning, their heart rhythm is probably okay. They just stopped breathing. When they're struck by lightning, or sometimes when they're electrocuted, it resets the breathing mechanism in the brainstem, the bottom part of the brain, and they stop breathing. So if you do rescue breathing for that person, they often will come back. But with CPR, all that does is basically keeps the organs alive until you can shock them back to normal rhythm with a defibrillator. And that only works for about maybe 8 minutes. So even in the best of hands, CPR only works for 8 minutes. The problem is that EMS often takes more than 8 minutes to get there, emergency medical services. So that's why the community, you guys, are kind of the key to keeping people alive by doing CPR and by having defibrillators available to shock people back to life. So it really does matter. Time does matter. I'm a New Yorker, New York City. It takes EMS 12 minutes on average to arrive at a cardiac arrest. And they have a 2% survival of out-of-hospital cardiac arrest. In Seattle, Washington, which has the most premier EMS system in the country, they have a survival of 30%, but that's because it only takes them on average 7 minutes to get on site. So that's one of the issues. So the more AEDs we have, the better. Do you guys have an AED on site here? Great. One of the problems is that a lot of times AEDs are available, but people are afraid to use them. And that's why I brought one here today that people can play with a little bit. There was a sad story in North Jersey where there was a baseball player, I think 12 at the time, was hit with a line drive. It was the pitcher. Was hit with a line drive. His heart stopped. They had an AED right there. Nobody used it. It was 18 minutes before the police arrived. And because he was young, he survived. But he has no brain function. He's on a feeding tube. He's on a ventilator. I mean, the kid's been like that for 6 years. That's not life. I mean, that's a real shame. And the defibrillator was there. He could have been fine. But everybody was afraid to use it. Nobody knew how to use it. So what is an AED? It's a computerized defibrillator. You hook people up to it. It automatically analyzes what's happening with the heart. It can't hurt them. It won't shock them unless they're dead. And if they're dead, you can't make them any more dead. You can't hurt them at all at that point. So you just shock them. It delivers an electric shock to reset the heart. So the bottom line is, let's turn sudden death into sudden victory. You know, like politically correct now, they're trying to turn baseball, I mean not baseball, but in like soccer and football and lacrosse and all those kind of sports, it's now sudden victory instead of sudden death. Unfortunately with heart, it's still sudden death. So let's get some sudden victory. The community, you guys are the ultimate coronary care unit. You know, if the patient, 30% of those people are dead before they ever get to me. Get trained in CPR. Know the basics. That at least keeps them going for at least the 8 minutes. It gives them a chance. Get trained in the use of a defibrillator. We'll do a little show and tell here on that. But if you have training courses here on site, everybody here on site should know how to use it, because maybe everybody leaves, you're stuck late on a Friday or whatever, somebody goes down, you're the one who may be required to save that person. And promote increased availabilities of AEDs in your community. I don't own stock in these companies or anything like that. It's just the more available they are, the better off people are going to be. Our goal, and as cardiologists, the American Heart Association, is to get these things as ubiquitous as fire extinguishers. You know, when have you ever used a fire extinguisher? Never, but they're everywhere. That's the way AEDs should be. You don't have to worry about getting a new hairdo with them. You really can't hurt yourself, even if you're touching the patient. So what do? First is prevention. Know whether you, your family, are at risk for heart disease, and try to address those modifiable risk factors to prevent heart disease from ever occurring in the first place. Watch for signs of distress. If something bad happens, think the worst, expect the worst, but hope for the best. So hopefully, they just passed out. You know, it's a boring sermon in church. The guy passed out because it was too hot. That's why he went down. But maybe it's something bad happened, so call 911. If they get there and you have to call them back and say, oh no, the patient woke up, they're fine. That's okay. Every second counts. Be prepared with your BLS, your CPR training, and know how to use an AED, and try to make the AEDs more available. So in summary, everybody is at risk. Everybody's at risk for heart disease, some more than others.
Can you define heart disease? Is it that scarring?
I'm talking about coronary artery disease predominantly. So when we use the term heart disease, there's 1,000 things that can be heart disease. But today I'm primarily talking about coronary artery disease, when the arteries that serve the heart muscle get blocked. So that's what we're talking about. But everybody's at risk for that to some extent, some more than others. Things that I do, medical therapy, the stents, the bypasses, all the fancy things we do, those are Band-Aids. It's after the horse is out of the barn, we're trying to, pin up the barn door again. The best thing is to try to prevent it from ever happening in the first place. And you're never too young to do it, nor are you ever too old to do it either. So even if you're 70 years old and you think, oh, my time's done, no, because keeping the cholesterol down, the plaque is still there. It doesn't go away, but it doesn't crack open. When your cholesterol is very high and you have one of those plaques, it's like jello, I should say. So it's kind of moving around. It's more likely to have that fibrous cap, that tissue paper, crack open. If you lower your cholesterol, then it's like cement underneath there. So the plaque is still there, the blockage is still there, but it's much less likely to crack open. So it prevents heart disease. So that's it. I'll open it up for any other questions you guys have.
So
Yes.
there's a CT scan can tell the condition, or?
Yeah, there's a test there's two types of CT scans we do. One is called the coronary calcium score. That's a fair test. What that does is when people have plaque in their arteries, most likely there's calcium associated with that plaque. So this is a very quick, low-cost CT. It's not paid for by insurance, but you can get it done for $99 at your local hospital does it. And they look to see if there's any calcium in the arteries. And the amount of calcium is kind of related to what your cardiovascular risk is. The problem with that test is that young people under age 50 can have plaque in their arteries without calcium yet. So you might have a 40-year-old who has a lot of plaque but no calcium. You tell them, you're fine. And they have a heart attack a week later. And people over age 50, 50% of people have some calcium already. So in some extent it could be helpful, but in most cases it just tells you whether you're above or younger than 50. So I don't think that's a great test. There's another test that's out there called a CT angiogram. You've all have heard of the term heart catheterization, where we go up through the leg or through the wrist and inject X-ray dye into the heart arteries to see what the lumen, what the opening of the artery looks like. We can do the same type of test with the CAT scan without ever entering the body. We just put an IV in, inject X-ray dye, and we take a look at it. The problem with that is that it's not the same resolution of a heart cath. Pretty good. It's still a lot of radiation exposure. It's about 16 or 30 times the amount of radiation exposure of a chest X-ray. So especially in women, it's an issue because you don't want to be radiating the breast tissue, which is right there. And then it's also an X-ray dye exposure, so that can affect the kidneys and that sort of thing. The worst part about it is the insurances generally don't pay for it, and that's a $2,000 test. So those are out there, those are available. They have some usages, but not in the mainstream yet.
So those are not the CAT scan.
What's that?
The two earlier we talked about, they are not X-ray.
Well, both of them are CAT scanners. One is where we're just looking at calcium with a very small amount of radiation. A chest X-ray is like 0.5 units of radiation. The calcium score is 2 units of radiation. The coronary CT angiogram, where we look at the whole arteries and stuff, that's about 16 units of radiation. So that kind of gives you the amount of radiation.
CAT scan is 3 units.
CAT scan has radiation associated with it.
What about the other type called EMR or something?
Yeah, that can, because of the motion of the heart, they can't do the MRI fast enough to see the heart arteries. They can only see the proximal 1/3 of the arteries, and so that has not been helpful.
My husband had the second test that you
The
talked
CT
about.
angiogram, yeah?
Yeah, but that's made it very difficult for him to get health insurance.
Right.
And
That-
life insurance.
Yeah, that's the
things like
thing. And the thing is, if they see even a little bit of plaque, and most people over age 50 are going to have some plaque, all of a sudden the insurance companies don't want to give you life insurance anymore. So that can be an issue. But you still, the only time I use the test, I'll use the calcium score, is if somebody has a high cholesterol and they want to know, I really don't want to take a cholesterol medicine, should I? Well, if they have plaque in their arteries with calcium, then they really should. So that's really the only time I use it, is when we're trying to debating whether somebody should be on a, they don't, I say they should, they say they shouldn't, and we kind of use that as a tiebreaker. But they're ultimately the bosses. So. Any other questions at all?
Hi, one. This is kind of related to what you said. I've been taking cholesterol medicine, but over like the past 2 years, my cholesterol has come down a lot. And not just because of medicine. I mean, I've lost weight and exercise regularly. And all
See,
like
he's
that.
doing the whole package, guys.
But so the last time I went to the doctor, I mean, my cholesterol was down more, and I was thinking, well, he's going to take me off this medicine, or at least cut it back from 40 to 20 or something.
Which
and he didn't.
Yeah, that's.
And I'm just kind of like.
Well, it depends on where the number is. So if you, and it depends on your other risk factors and that sort of thing. But say I have somebody who has had coronary artery disease, and their cholesterol is down to 30. Their LDL, their bad cholesterol, is down to 30. It doesn't need to be that low. I might say, gee, you're on 20 of Crestor now. Let's drop you down to 10. and then recheck it. And if it goes up to 90, then we got to go back up to the higher dose. But if it stays down below 70, then I'm okay. So I would agree with you on that. You can't stop the medicine completely because it's the liver. As soon as you stop, the liver will go back to making the same as it did before. So 20% of your cholesterol drop, you get credit for from the exercise and losing weight and dieting and all that. But the other 80% of drop comes from the medications affecting what your liver is making. So what we'll do is just in our last minute or two here, because I think we have to be at the other place at 12:30. We're going to Fountainhead. Is that close by?
Yeah, a couple miles.
So everybody can come around. Who has been trained on how to use these things? Okay. That's great that you three are trained. It's bad that everybody else hasn't been trained. So this is a blow-up dummy. They have these, the American Heart Association sells these. They're only for use for CPR training. You can use this to train, to do CPRs. So it gives you a click to let you know if you're pushing hard enough, sometimes. So if you don't hear the click, that means you're not pushing hard enough. So these are kind of things that you want to have a party sometime. Hey, let's have a CPR party. I'm kind of a dull guy. But anyway, it's something you can do. So the defibrillators, they tell you what to do. So say, I never did CPR training, I never did anything. All you do is open up the box. Who wants to be our dummy to try? You want to give it a try? No, this is a fake one. So you'll see a pack. Some of these are plastic containers of patches. You pull it out. These are the pads. And usually, what's that? Yeah, they talk to you. Now, these have been used a couple times.
One pad from plastic liner. Peel one pad from plastic liner.
See?
Place one pad on bare upper chest. Place one pad on bare upper chest.
Sometimes they're connected on the same piece of foil in the middle. Sometimes they're totally separate.
Peel second pad, then place on bare lower chest as shown.
You don't want the two touching, okay? And the other thing is you don't want to be, if the chest is wet, you want to try to dry the chest. Let's say it's raining outside, because you don't want the electric shock to arc across the chest. You want it to go through the body.
Do not touch patient. Analyzing rhythm.
So now it's looking at the patient's rhythm. And then once there's a shock advised, some will automatically shock. Most you have to push a button. So there's a flashing button that tells you to push. You push it, shocks them, they jump up in the air.
It is now safe to touch the patient.
And then they want you to start doing CPR.
Give 30 compressions. Then give 2 breaths.
And it goes through the cadence, so you don't have to worry about doing your cadence or singing Staying Alive or anything like that. I'm not a good singer. So that's basically how they work. So they're really, it's great that you have them here. Everybody needs to know how to use them, be familiar where it is, how to use it. Again, you cannot hurt somebody. It will not shock the person if they're alive, if they have a normal rhythm. It will only shock them if they're dead, if they have that ventricular fibrillation we talked about. So that's about it. Any questions about that?
Hold the dummy up first so I can see where you put them patches on.
One goes in the front and one goes off to the side, the left side.
So you put one kind of like in the center here, and then one over here.
Exactly.
Left side.
Left side, left side.
The other left.
I have trouble with that too.
Yeah.
I said, which hand do I salute my self with?
Yeah.
You want the electricity to go through that
Right.
path from one pad to the other.
Now, if you have
I
a
see.
kid, say you have a 9-year-old and they're really small and they're like, oh my gosh, they're going to touch. You can always put one in the front and one in the back, upper back. So that. You know, I'm not supposed to have told you that, but that's what we do all the time. And these patches, now the machines are different. So this is one called Cardiac Science. I'm not sure what yours looks like. This one actually will give an amount of energy proportional to the patient's size. So if it's a really small kid, it gives them smaller energy because it senses the impedance, the electrical resistance between the two pads. If it's a real small person, it gives them a small amount. If it's a big person, it gives them a bigger amount. The Philips ones, which are in a red box, I'm not sure what yours look like.
Ours is bright yellow.
Bright yellow is probably a Medtronic then.
Yeah.
The Philips ones have a little pink key that you put in the top, so it decreases the energy in a kid. But again, if you can't find the pink key, don't worry. The shock doesn't damage them. All it does is give them a little bigger sunburn. So if a kid's dead and you're going to save them, don't worry about finding the pink key. Okay, but just so you know that they do exist. Any other questions? Okay, well, thanks for coming.
Thank
and
you.
You guys have my card. Any questions you have, give us